Thank you very much, Dr. Vitul. First of all, I must extend my thanks and greetings from Innovative Physicians Forum. Dr. Vitul himself is also a academic life member of Innovative Physician Forum, which is a body of all academic people. And then I am thankful to him again for giving me this topic and giving our Innovative Physician Forum a platform in this important conference, where, as I have been told, a good number of people have joined online. So, in next say 20 or 19 minutes, I will be taking you through a very important topic, and that is type 1 diabetes and cardiovascular risk. We all have been reading about, listening about the micro and macrovascular complications, but when we talk of these complications, it comes to our mind that it is of type 2 diabetes. Because these complications, they start much before the clinical diagnosis of diabetes is there. As we all know, the beta cells start failing, or their work goes down by 5 to 6% every year. So by the 10th year, 50 to 60% of beta cell function has already gone down, and the remaining 40 to 50% beta cells are not enough to produce insulin, which will be sufficient to keep the patient in the euglycemic phase. And that is the time when the micro and macrovascular complications start. But this is all about type 2 diabetes, which we say, because in type 1 diabetes the things are different. As it is well known that diabetes is a complex chronic condition which requires continuous medical care with multifactorial risk reduction strategies beyond the glucose management. So it is not only the glucose management. Nowadays, earlier it was the glucose-centric approach, and now it is the patient-centric approach in the management of diabetes. And type 1 diabetes, which is an autoimmune disease that leads to the destruction of insulin producing pancreatic beta cells, and there is heterogeneity in the metabolic, genetic and the immunogenetic characteristics of type 1 diabetes, and age related differences requiring a personalized approach for each individuals. And that is the reason that many of us who are treating diabetes, 90% of the people are treating type 2 diabetes only. Because it is, you should have a passion to treat type 1 diabetes. Patient demand, the family demand, and self-satisfaction, which is very, very important. Cardiovascular disease is a long-term complications of even type 1 diabetes that is a major concern for patients and healthcare providers. And these events are more common and occur earlier in patients with type 1 diabetes than in the non-diabetic population. So when we compare the non-diabetic with the type 1, definitely they come early, and the overall risk of the cardiovascular disease for people with type 1 compared to people without a diabetes is increased 2 to 3 fold in men and 3 to 5 fold in women. So a significant increase in the cardiovascular death mortality related to increasing the HbA1c has been reported in type 1 diabetes patients. And talking about the epidemiology in the EuroDiab IDDM complication study, where including more than 200 patients with type 1 diabetes from 16 European countries, prevalence of CVD has reported to be 9% in men and 10% in women respectively. And according to the results of a large Finnish database, CVD mortality in patients with type 1 diabetes at the age of 45 to 64 years at baseline increases by 50% with every 1% increase of the HbA1c. This does not mean that the people are only from 45 to 64 years. Type 1 diabetes, as we know that it develops early, though we can see the patients of the adult patients also with type 1 diabetes in certain situations. Now there are certain important factors which contribute and disease progression in type 1 diabetes. You can see that the genetic risk, which is the foremost, starting point 15 times increased risk of type 1 in those with relatives with disease. So if there is a relative with disease, then we have to screen them first, and then the immune activation, that beta cells are attacked through the immune activation, leading to development of single autoantibodies. Coming to the stage 1, 2, 3 and 4, when the blood sugar levels are normal and if there are 2 or more autoantibodies, that is the stage 1. But when the blood sugars they become abnormal, then it goes to stage 2. And when there is clinical diagnosis of this diabetes, then plus. And when there are 2 or more than 2 autoantibodies, this is stage 3. And stage 4 is that when long-standing type 1 diabetes is there. Coming to the immunopathogenesis of type 1 diabetes, the development of type 1 is thought to be initiated by presentation of beta cell peptides by antigen presenting cells, that is the APCs. And these APCs bearing these autoantigens, they migrate to the pancreatic lymph nodes where they interact with autoreactive CD4 plus T lymphocytes, which in turn mediate the activation of autoreactive CD8 plus T cells. So, and this is the immunopathogenesis. But when we talk of the pathophysiology, long-term hyperglycemia both in type 1 and type 2 diabetes, they lead to microvascular and macrovascular complications. And the microvascular damage affects particularly the retina, the kidneys, both the autonomic and the peripheral nervous system, while the heart, brain, lower limb are affected by both micro and macrovascular disorders. Now this is a very important slide, and we just have to put some mechanism of vascular damage in type 1 diabetes and their putative amplification by a dysfunctional immune response. We know that when there is decreased central immune tolerance to self, which is the pathogenesis of type 1 diabetes, and on the top of that, when there is environmental, like if there is a viral infection, so when there is viral infection that leads to, and when the subject is genetically susceptible, beta cell destruction starts, and that is type 1 diabetes. Hyperglycemia is there, and on the other side, through the anti-myosin antibodies, they all lead to systemic inflammation and subclinical myocarditis. But through the hyperglycemia, when we see the oxidative stress, through these 4 very common pathways, the hexosamin pathway, the polyol, PKC and aegis pathways, and when on the top of that, if there is hypertension, then microcirculatory damage, tissue hypoxia, inflammation, and they all lead to these complications of nephropathy, retinopathy, neuropathy, atherosclerotic vascular disease and heart failure. So, type 1 diabetes is considered to result from dysfunctional tolerance to the self antigens in susceptible individuals after exposure to incompletely understood environmental factors like the viral infection, which we do not know much about that. Now, the risk factor for the microvascular complications influenced by several factors like the puberty, the blood pressure, dyslipidemia, gender, diabetes duration, smoking and the lifestyle, and the poor metabolic control that was identified as an important factor contributing to the microvascular complications. When you look at the relative association between specific cardiovascular risk factors and CVD in type 1 versus type 2 diabetes, you can see that hypertension, cigarette smoking, inflammation, they all have a significant effect on both type 1 and type 2, but high LDL cholesterol in type 2, low SDL cholesterol in type 1. On triglycerides, there are no data available on type 1 diabetes, microalbuminuria on both sides. Insulin resistance is more in type 2 diabetic patients, and poor glycemic control, of course, in both type 1 and type 2. And this is the cardiovascular risk engine, where you can see in the various studies the steno T1, UKPDS and the Q risk, where we can see that the LDL, exercise, diabetes duration, HbA1c, age, gender, systolic blood pressure, smoking, total cholesterol, SDL ratio, ethnicity, atrial fibrillation, migraine, corticosteroids. So, all these, they are the various cardiovascular risk engines. Now, the level of cardiac autoantibodies in subjects from the different groups, we see that cardiac autoantibodies in type 1 are directly associated with the glycemic control. More the HbA1c levels, more is the risk of CVD in type 1 diabetic patients. And when we look at the heart rate function, any CVD and the MACE, Intensive diabetes therapy during the DCCT trial for 6.5 years has long-term beneficial effect on the incidence of cardiovascular disease in type 1 diabetes that persists for up to 30 years. Cardiovascular events in type 1 diabetes, again we see that the intensive diabetes therapy has long-term beneficial effect on the risk of cardiovascular disease in patients with type 1 diabetes. Then intima media thickness. Mean progression of the intima media thickness was significantly less in the group that had received intensive therapy during the DCCT than in the group that had received conventional therapy. Intensive therapy during the DCCT resulted in decreased progression of intima media thickness 6 years after the end of the trial. So, they all show that better control, intensive control of diabetes is very, very important here. And the benefits of this intensive glycemic control, early intervention designed to optimize glycemic control have been shown to reduce the development and progression of these complications. And the participants in the DCCT with further follow-up in the ADIC study, they demonstrated all this. And in the year 2005, 10 years after the completion of DCCT, reported that the period of initial intensive diabetes therapy also reduced the risk of developing cardiovascular disease, and the 30-year follow-up also showed CV benefits upon intensive glycemic control. So, intensive glycemic control is very, very important in these patients, but take care of patients should not go into hypoglycemia. Now, when to screen for the cardiovascular disease in these patients? In symptomatic individuals, routine screening for coronary artery disease is not recommended. In asymptomatic individuals, as it does not improve the outcome as long as atherosclerotic cardiovascular disease risk factors are treated. And consider the investigation for coronary artery disease in the presence of any of the following: atypical cardiac symptoms like unexplained dyspnea, chest discomfort, sign or symptoms of associated vascular disease like the carotid bruit, transient ischemic attack, stroke, claudication or peripheral arterial disease, or the electrocardiographic abnormalities like Q waves. So, then we must definitely screen, and these are the various risk factors which I have tabled into this: hyperglycemia, CKD, dyslipidemia, then the hypertension. All these they should be considered when we screen and when we treat type 1 diabetes patients. Blood pressure is very important. It should be measured at every routine visit. In youth with high blood pressure of more than 90th percentile for age, sex and height, or in adolescents more than 13 years, blood pressure of 120/80. More than 120/80 on 3 separate measurements, ambulatory blood pressure monitoring should be strongly considered. And treatment of elevated blood pressure defined as 90th percentile of 90th or to less than 95th percentile for age, sex and height, or in adolescents more than 13 years. Lifestyle modification focused on healthy nutrition, physical activity, sleep, and if appropriate weight management, and after that if required then we have to go for the pharmacotherapeutics. This is the recommendation for the treatment of confirmed hypertension in people with diabetes. And then the lipids, type 1 diabetes adolescents, initial lipid profile should be performed soon after the diagnosis, preferably after glycemia has improved and age is more than 2 years. If initial LDL is 100 or less than 100, subsequent testing should be performed at age 9 to 11 years of age, and initial testing will be done with a non-fasting lipid level with confirmatory testing with a fasting lipid panel. Then lifestyle modification focusing on weight loss if indicated, application of a Mediterranean or dietary approach to stop hypertension, patient reduction of saturated fat and trans fat, increase of the dietary N3 fatty acids, viscous fiber and plant sterols intake, and the increased physical activity should be recommended to improve the lipid profile and reduce the risk of developing atherosclerotic cardiovascular disease. And for people with diabetes aged 40 to 75 years without atherosclerosis cardiovascular disease, use moderate intensity statin therapy in addition to the lifestyle therapy. This is the another very important factor, the smoking and the pollution. Elicit a smoking history at initial and follow-up diabetes visits. Discourage smoking in youth who do not smoke and encourage smoking cessation in those who do smoke, and also look after the passive smoking. Electronic cigarettes use should be discouraged. Glycemic control, less stringent A1C goals may be appropriate for youth who cannot articulate symptoms of hypoglycemia. So prevent hypoglycemia. Even less stringent A1C goals such as less than 8 may be appropriate for individuals with a history of severe hypoglycemia, limited life expectancy, or where the harm of treatment are greater than the benefits. It does not mean that these patients, only type 2 diabetic patients, they reach to this stage. Even type 1 diabetic patients also have a long life. Now look at the microvascular complications, neuronal damage and structural damage, diabetic retinopathy. Look for diabetic nephropathy, diabetic neuropathy, and other non-classic targets like the microangiopathy and the metabolic damages, and macrovascular, of course, for the lower limb, microangiopathy and the metabolic damage, coronary artery disease and stroke. Of course, we have to look for that. Now, one very important but neglected component of the complications of diabetes is the diabetic autonomic neuropathy. Diabetic autonomic neuropathy remains underdiagnosed, thus contributing to the morbidity of diabetes and may not be reversible. ADA recommends screening for DAN at the time of diagnosis of type 2 and 5 years after the diagnosis of type 1 diabetes mellitus. Diabetic autonomic neuropathy is an under-recognized complication of diabetes and the pre-diabetes state. Wide range of manifestations can be seen due to involvement of cardiovascular, gastrointestinal, genitourinary, pseudomotor and the neuroendocrine system. Cardiac autonomic neuropathy is the most dreaded complication carrying significant mortality and morbidity. Early detection and control of diabetes and other cardiovascular risk factors is the key to treat and prevent progression of autonomic neuropathy. So please do not forget this and go for this. This is the overview of diabetes cardiovascular complications. You see here that coronary artery disease, heart failure, peripheral arterial disease, stroke, nephropathy, neuropathy and the retinopathy. And one very important the complications I can say is the erectile dysfunction, which I have not mentioned in detail, but that is very, very important. Any patient of diabetes coming to you with erectile dysfunction, please look for and evaluate for the cardiovascular disease. Because when there is constriction of the penile artery, if there is erectile dysfunction, of course, the patient will have the cardiovascular disease, and please evaluate for that. This is the type 1 to 2% of the patient are type 1 and type 2 are 98% of the diabetes. Major modifiable risk factors I have already told you, and control of the risk factors, especially the blood glucose as parameter for cardiovascular disease prevention in diabetes is very important. So dear friends, to conclude, type 1 diabetes remains one of the biggest global health concern in the world. In the last 4 decades, the number of patients diagnosed with type 1 diabetes has steadily increased. Complications associated with diabetes culminate in an increased risk of neuropathy, retinopathy, nephropathy and the cardiovascular events. Enhanced form of exogenous insulin replacement have improved the quality of life in type 1 diabetic patients through fast and long-acting insulin analogs. Their overall life quality and life expectancy is decreased. There is enormous need for the development of new approaches for prevention and treatment of type 1 diabetes, and any healthcare provider looking after the type 1 diabetic patient should have a zeal and a passion to look after these patients. So type 1 diabetes does not just alter insulin production. It alters the cardiovascular equation. Every effort to control blood sugar level is a step towards reducing the risk of heart complications in these type 1 diabetic patients. And with that, I thank everyone, and my special thanks to Professor Vitul Gupta and the entire team for this wonderful conference and giving us the opportunity. Thank you very much, sir.